Assalamualaikum and good morning IB to Madam Nurul and my fellow friends. My name is Nurhana Christina binti Omar. So today I will be presenting on shoulder internal rotation, focusing on both its anatomy and radiographic aspects. First, I will explain the basic anatomy of the shoulder joint, followed by the radiographic anatomy to show how these structures appear in imaging. Then, I will discuss the parts involved and patient positioning, including how to recognize whether the positioning is correct or incorrect. After that, I will briefly introduce the Passman method for evaluating image quality. And finally, I will end my presentation with a quiz sessions. Now, I will explain the anatomy of the shoulder. So, the first one is sternoclavicular joint. The second one is clavicle. The third one is acromioclavicular joint. The next one is acromion. Next is coracoid process. Next is glenoid cavity. The next one is glenohumeral joint. Next is the head of humerus. Next, scapula. And the last one is humerus. Next, I will present the radiographic anatomy of the shoulder. The first one is clavicle. The second one is acromion. The third one is coracoid process. Next, humeral head. Next, greater tuberosity. Next, scapula. Next, glenoid. Next, lesser tuberosity. And the last one, humerus shaft. The next slide is positioning. I will explain on the correct and incorrect positioning. Before that, I will explain the patient and part position. For the patient position, the radiograph is performed with the patient is an erect or supine position. The body is rotated slightly towards the affected side, if necessary, to place the shoulder in contact with the IR or tabletop. And for the part position, the patient is positioned to center the scapulohumeral joint to the center of the IR. The arm is slightly abducted and extended. Then, the arm is internally rotated by pronating the hand until the epicondyles of the distal humerus are perpendicular to the IR. As you can see in the video, focus on the arm that is internally rotated. That is how you perform internal rotation for the shoulder. Next, I will explain the correct positioning for the epi-internal shoulder. In this radiograph, the greater tuberosity is not visualized in lateral profile because it is rotated posteriorly during internal rotation. The lesser tuberosity is partially superimposed over the humeral head, which is an important sign of correct internal rotation. The glenohumeral joint space is preserved, meaning there is no significant overlap and the joint can be clearly assessed. All the features indicate that the arm has been properly internally rotated and the positioning is correct. Next, I will explain the incorrect positioning. In this radiograph, the greater tuberosity is visualized in lateral profile, which indicates that the arm is not fully internally rotated. The lesser tuberosity is superimposed over the humeral head. The glenohumeral joint space is fully closed, making it difficult to clearly assess the joint. This image shows incomplete internal rotation due to under-rotation of the humerus. Therefore, the positioning is incorrect and further internal rotation of the arm is needed to obtain the correct view. Next, I will explain the projection of this radiograph. This is a radiograph of a shoulder epi-internal. This is identified as a shoulder because the important structures are included in the exposure field. The glenohumeral joint space is shown in blue, the clavicle is marked in red, the coracoid process is indicated in yellow, and the superior scapula is shown in green. This is an epi-internal projection because the lesser tuberosity is seen in profile medially, which is shown by the blue line. The greater tubercle is superimposed on the humeral head, indicated by the yellow line. These features confirm that the arm is in internal rotation. Moving on to the next slides, I will explain the positioning for this projection. So, the positioning in this image is incorrect. This is because there is evidence of rotation. The greater tuberosity is clearly seen in lateral profile, which is indicated by the green line, and it is not superimposed medially. The lesser tuberosity is superimposed over the humeral head as shown by the pink line. These findings indicate that the arm is not properly internally rotated. So, to improve this positioning, the arm should be internally rotated further until the MSP is perpendicular to the IR. Moving on to the next slide, I will explain the alignment. In this radiograph, the alignment between atrial tube and cassette cannot be determined because there is no four borders of collimation. The alignment between atrial tube and patient cannot be determined because there is no four borders of collimation. The alignment between patient and cassette also cannot be determined because there is no four borders of collimation. In addition, the centering point for this radiograph cannot be determined because there is no four borders of collimation. However, the standard centering point for this projection should be 1 inch inferior to the coracoid process as shown in the image. Next, I will explain on the collimation part. For the superior border, the structure included are the acromyon, head of humerus, and coracoid process. You can see in the image, it is in the blue line. Next, for the inferior border, the structure included are the lesser tubercle, surgical neck humerus, and greater tubercle. It is shown in the pink line. As for the lateral border, the structure included are the clavicle and the fourth ribs. You can see in the image in the purple line. The bony cortical outline of the teeth structure, which is the acromyon, can be seen, and the bony cortical outline of the teeth structure, which is the coracoid and glenoid fossa, also can be seen. So, the KVP used is adequate for penetration and radiographic contrast. As for density, the bony trabecular pattern of the thin structure, which is the acromyon, can be seen, and the bony trabecular pattern of the thick structure, which is the coracoid and glenoid fossa, also can be seen. So, the MAS used is adequate for detail and density. Next, I will explain the markers. There is evidence of an anatomical marker shown in the radiograph. The marker is correctly placed on the left side of the body as indicated by the letter L in the image, which is circled in red. The marker is also appropriately positioned as it does not superimpose any region of interest. Therefore, the anatomical marker is correctly used in this radiograph. Moving on to the next slides, I will explain the aesthetic of this radiograph. The film size used is 24 times 30 cm and it is placed crosswise, which is sufficient to demonstrate all the structures of interest. In addition, there is no evidence of any artifact on the radiograph that could affect image quality. Therefore, the overall image appearance is acceptable. Moving on to the next slide, I will explain on the name part. The patient's name and ID, as well as the date of examination and place of examination, are clearly visualized on the radiograph. This information is important for patient identification and documentation purposes. Therefore, the radiograph is properly labeled with complete patient details. Now, I will explain the diagnostic acceptability in more detail. So, for this radiograph, it is considered not acceptable because it contains several major errors. Firstly, there is no patient information such as the name, ID, date, and place of examination. This is very important for patient identification, and without it, the radiograph cannot be verified. Secondly, there is no anatomical marker shown on the radiograph. This can cause confusion in identifying the correct side of the body. Thirdly, there is evidence of rotation which indicates incorrect positioning. This affects the accuracy of the image and may lead to misinterpretation. According to the hierarchy of errors, these issues are considered serious error that require a repeat examination. Other serious errors include structure cutoff and incorrect exposure as they can affect diagnosis. However, some error may still be tolerated, such as minor rotation, small artifacts, or lack of collimation, as long as they do not affect diagnosis. Therefore, radiographers must use clinical judgment, considering the risk and benefit before deciding to repeat an examination. This is the reference that I'm using it for my presentation.